Hello guys, welcome to AMC Prep Talks. So today we are going to discuss the complications of MI, post-MI complication, post-myocardial infarction. And I would highlight the complications that are mentioned in the eTG guidelines, but we'll start with the basic information. So the complications post-MI are of 3 to 4 types. For example, they are of arrhythmic, and they can be ischemic, they can be mechanical, they are inflammatory and systemic complications. So on Medscape, they have given this table you can check out. So they have categorized every complication under these headings. So the arrhythmic complications are the most common in the initial days after within 1 to 3 days. And they can be heart blocks, atrial or ventricular arrhythmias. Then we have ischemic complication, which includes reinfarction, peri-infarct, or ischemia. And the patient can again get the MI, that is reinfarction. It is also in the initial days. Then we have the mechanical complications, which are the most fearsome complications. And ventricular fibrillation is also a very fearsome complication. And then we have mechanical complications, in which we have mitral valve or quadritympany rupture, papillary muscles rupture, ventricular free wall rupture, or ventricular septal rupture, tamponade and aneurysm. These are the mechanical complications, and they manifest within the first week to first month. Then we have inflammatory complications that are pericarditis or post-MI Dressler syndrome. Post-MI Dressler syndrome is actually considered to be the autoimmune process, and these are shown in the first week to a month. Then we have the systemic complication that are cardiogenic shock, heart failure, embolic cerebrovascular accident, or systemic embolus. So this is the summarized table of post-MI complications. Now, starting with the individual complications. So in eTG guidelines, main 3 complications are written there, that are left ventricular failure, cardiogenic shock, and mural thrombus. And we will also discuss other complications. Starting with the left ventricular failure, if there is large infarct or in patients with prior left ventricular dysfunction, if the patient has already history of left ventricular dysfunction and he gets the MI, he is on a greater risk for left ventricular failure. And if there is mild episode of acute pulmonary edema, diuretics can be given with the recent MI. And in the cases of more severe episodes where there is increased amount of greater pulmonary edema, these would be more severe episodes, and treatment of acute cardiogenic edema would be considered in this case. We will also discuss acute cardiogenic edema later in this video. So basically, left ventricular failure can be is manifested by the presence of pulmonary edema. Right ventricular failure is also the complication of MI, and in that case, there would be the raised JVP, and there would be peripheral edema would be there. Then we have cardiogenic shock, and cardiogenic shock is the systemic complication of MI. And it is manifested when there is significant reduction in cardiac output, and this is manifested as the hypotension with the signs of impaired perfusion, including oliguria, cyanosis, cold peripheries, altered mentation. And the causes of cardiogenic shock can be the left ventricular failure or rupture, and there are other causes of cardiogenic shock. And it is actually when the heart is not able to pump enough blood and the cardiac output is decreased. So management is early coronary angiography or revascularization is indicated in the cases of cardiogenic shock secondary to myocardial infarction. And hemodynamic support is also given, that is adrenaline through central venous line. So the management of cardiogenic shock, which is secondary to MI, is early coronary angiography and revascularization plus hemodynamic stability and support. And if the patient has sudden clinical deterioration post-MI, there's the possibility of cardiac rupture. And these can be papillary muscle rupture or especially the ventricular free wall rupture. So these cases are presented with the sudden clinical deterioration, and these are very lethal complications, and mortality rate is very high in such mechanical complications. And the papillary muscle that is most likely to be ruptured is posterior medial. Posterior medial papillary muscle is most commonly ruptured. Then we have the mural thrombus. Left ventricular mural thrombus on imaging is if we do the imaging and there is a left ventricular mural thrombus present on imaging and the patient of MI, anticoagulation is indicated, and in this case warfarin is preferred. But initially, low molecular weight heparin or unfractionated heparin parenteral anticoagulation must be given initially to overcome delay in the delay, and the warfarin is the preferred anticoagulation, and the patient anticoagulation is advised unless the mural thrombus gets resolved, and sometimes the mural thrombus is present lifelong, so lifelong anticoagulation is also considered. Then we have bradyarrhythmias and tachyarrhythmias. Risk of serious arrhythmia such as ventricular fibrillation is greatest in the first hour. Then we have the pericarditis. Post-MI pericarditis would present as the normal pericarditis, as the chest pain which is increased on inspiration, and the spuritic chest pain, and the patient would have the diffuse ST elevation on the ECG, and only NSAIDs and aspirin is given, and the symptomatic treatment is given in this case. Then we have Dressler syndrome. It is believed to be the autoimmune process post-MI, and it is presented with the fever, chest pain, and other signs and symptoms of pericarditis, mostly 2 to 3 weeks after MI. High dose of aspirin is given in this case, and NSAIDs and corticosteroids are avoided in this case. Then we have the acute cardiogenic pulmonary edema. Acute cardiogenic pulmonary edema is actually the pulmonary edema that is secondary to cardiogenic, acute cardiogenic causes. And there are two pathological processes, that is intra-alveolar fluid accumulation or extreme sympathetic activation. And acute cardiogenic pulmonary edema is actually secondary to heart failure, and that is the left ventricular failure most often. It can be post-MI or some other causes of heart failure. So it is actually the medical emergency, and it presents as a rapid onset of severe dyspnea, often first occurring at night, and tachypnea and tachycardia, and patient would present as he is unable to lie down, and when he lie down, he gets shortness of breath, which is termed as the orthopnea. On examination, there would be sweaty, cool peripheries, reduced capillary return, patient would be agitated and restless, widespread lung crackles would be there, and if it is left untreated, exhaustion and altered level of consciousness can present. So management of acute cardiogenic pulmonary edema. Initially, it is managed in pre-hospital management would be to sit upright, to advise the patient to sit upright, and an ambulance 20 to 80 milligrams of furosemide can be given, which is repeated 20 minutes. And IV and IM furosemide is given. SpO2, if SpO2 is less than 92%, high flow oxygen is considered, and if the response is inadequate, we would consider the GTN, which is glycerol trinitrate. Then in the ER setting, we have to gain the IV access. ECG would be done, and blood pressure and pulse oximeter would be attached. If the patient had STEMI and he gets cardiogenic shock, if the patient had STEMI, means that the patient had a myocardial infarction, and the cardiogenic pulmonary edema is secondary to MI, we would consider immediate PCI or thrombolysis, and we can also consider other precipitants. For example, non-ST elevation, acute coronary syndrome, hypertensive emergencies, arrhythmias, mechanical, like mitral regurgitation due to acute valve dysfunction, ventricular septal defects. So these other precipitants would also be considered. But in the case of cardiogenic shock that is secondary to STEMI, immediate PCI and thrombolysis is indicated. We would pass the indwelling catheter for urine, and first furosemide is 20 to 80 milligrams of furosemide is given per 20 minutes, and glycerol trinitrate, and it is to maintain systolic blood pressure more than 90. And if the acute cardiogenic pulmonary edema remains severe and the symptoms remain severe and do not respond, we are going to be doing the non-invasive ventilation with 100% oxygen. That is the CPAP. And if the patient has difficulty tolerating the CPAP, we are going to administer the morphine. While administering the morphine, we have to monitor for sedation and indicator of opioid-induced ventricular impairment. So sedation is actually an indicator of opioid-induced ventricular impairment. And if atrial fibrillation is also there with rapid ventricular rate and there is poor cardiac output, we have to use the amiodarone. And if the atrial fibrillation is not responding and patient is deteriorating, we have to do the electrical cardioversion. And if the edema is not responding, especially if the patient is hypotensive and poorly perfused, we have to add the dobutamine. And treat hypotensive patient as the cardiogenic shock. If the patient do not respond and the signs of non-response are exhaustion, decreased level of consciousness, increased confusion or agitation, and patient has increasing PaCO2 and failure to maintain oxygen, partial pressure of oxygen adequately, we have to intubate the patient. So this was the management of acute cardiogenic pulmonary edema and the other complications of post-MI. Hope you like my video. And if you like my video, kindly share among your colleagues, subscribe my channel and like the video. Thank you.